Hello everyone, welcome back. In this section, I'm going to give a brief introduction of common epithelial neoplasms. After this section, students should be able to recognize the morphologic features of papilloma, tubular adenoma, cystadenoma, fibroadenoma, squamous cell carcinoma, adenocarcinoma, and basal cell carcinoma. Papillomas are benign warty growths in which the proliferating epithelium is flowed outwards into folds and does not invade the underlying connective tissue. Between these epithelial folds are cords of fibrous tissue and blood vessels, which help to nourish the epithelium. In general, the papilloma epithelium is well differentiated and closely resembles the epithelium of origin. To the naked eyes, they are usually small in size, solitary or multiple. Histologically, there are fibrovascular cords corresponding to the macroscopic finger-like fronds. They can arise on the skin surface or on the luminous surfaces of the visceral organ system, such as the gastrointestinal tract, respiratory tract, or urinary tract. Since both benign and malignant neoplasms may show a papillary appearance, a biopsy is needed to determine the specific nature of a papillary lesion. This picture shows the microscopic morphology of squamous papilloma of the skin. Please pay attention to its distinguishing feature. We can see the finger-like structure with a central fibrovascular core, covered by well-differentiated squamous epithelial cells. Adenomas are benign tumors of granular or ductal epithelium. They can be polypoid or nodular in growth appearance. The adenoma cells usually form granular structures. Tumor cells are well differentiated and often continue to produce secretions. Thus, the cells of a colonic adenoma may produce mucin or a phylloid adenoma, phylloxin. Based on their histological components, adenoma can be further divided into the following types: solid adenoma, tubular adenoma, cystadenoma, and fibroadenoma. Solid adenoma is usually a nodular tumor of well-differentiated granular epithelium. In fact, sometimes it may not be easy to distinguish an adenoma from hyperplastic tissue based on its microscopic structure. It is sharply demarcated from its surrounding tissue of origin and exhibits a smooth surface with a fibrous capsule. These two pictures show us the typical morphology of phylloid adenoma. On its cut surface, the mass is well encapsulated. Histologically, the tumor tissue contains mature follicles with colloid and are demarcated from the adjacent phylloid parenchyma by a well-defined, intact fibrous capsule. Tubular adenoma is generally a pediculate, superficially smooth nodule of proliferating epithelial tubules in the lumen of a hollow organ. This micrograph depicts the morphology of a tubular adenoma of the colon. The stalk is covered by normal colonic mucosa, but the head is composed of neoplastic epithelium, forming branching glands lined by tall, hyperchromatic cells. These branching glands are well separated by laminar propria. Cystadenoma consists of neoplastic granular cells that form single or multiple cysts due to the collection of secretion. They may be found in the ovary or pancreas. Sometimes, especially in the ovary, there is proliferation of epithelium within the cyst, often in the form of papillary structures, and the term papillary cystadenoma is used. The left image shows the gross appearance of an ovarian cystadenoma. This ovary has been sectioned to reveal multiple fluid-filled cavities which are smooth surfaced. This is a mucinous cystadenoma. Histologically, the cystic locules are filled with mucin and lined by tall columnar epithelium with uniform basal cell nuclei and abundant mucin-containing cytoplasm at the luminal aspect. Fibroadenoma is well-circumscribed mass containing both epithelial and stromal components. The epithelial component forms the glandular structure lined by mammary ductile epithelium, while the stromal element is a loose cellular form of fibrous tissue. In some cases, the stroma may be myxoid. Fibroadenomas are the most common benign neoplasms of the breast. Histologically, there is a loose fibroblastic stroma containing duct-like spaces of various forms and sizes. These duct-like or glandular spaces are lined with single or multiple cell layers with an intact basement membrane. The glandular lumens become compressed and folded as the stroma proliferates, creating slits or irregular structures. Squamous cell carcinomas are malignant neoplasms showing squamous or epidermoid differentiation in the form of keratin production or the presence of intercellular bridges. Squamous cell carcinomas may arise in any site of native stratified squamous epithelium, such as skin, tongue, esophagus, or uterine cervix. They may also evolve from squamous epithelium which has been transformed by the process of squamous metaplasia. Squamous cell carcinomas are locally invasive. They can also metastasize to regional lymph nodes and to distant organs. Macroscopically, squamous cell carcinomas are often ulcerative or polypoid in appearance. If they are very large, we can describe them as cauliflower-like or mushroom-like. Squamous cell carcinomas resemble normal squamous epithelium to a varying extent. Well-differentiated carcinoma, as seen in this picture, has cytological features similar to the prickle cell layer of normal squamous epithelium. The nuclei show a moderate degree of pleomorphism. These cells are commonly arranged in broad sheets and large necks. At very high magnification, intercellular bridges may be visible. The most characteristic feature of well-differentiated squamous cell carcinomas is the formation of keratin. This may be seen within individual cells, but more often we can detect lamellated pink stained masses known as keratin pearls. However, please note that poorly differentiated squamous cell carcinomas are pleomorphic and often lack intercellular bridges or keratin pearls. In this situation, immunohistochemistry may be needed to identify poorly differentiated squamous cell carcinomas. These tumors react with antibodies against cytokeratins. Adenocarcinoma is a malignant epithelial tumor having a glandular arrangement or origin. They are among the most common malignant epithelial tumors in the breast, respiratory, and GI tracts. They may be locally invasive, metastasize to regional lymph nodes and to distant organs. Macroscopically, adenocarcinomas may form polypoid masses or ulcers. Several types of adenocarcinomas may be identified according to their degree of differentiation and mucin production. Tubular adenocarcinoma is a highly differentiated form with well-defined glandular tubules. Some moderately differentiated adenocarcinomas appear either papillary or cribriform. The epithelium of the papillary carcinoma folds to form a tumor papilla. Examples include thyroid and ovarian carcinoma. The cribriform carcinoma shows a gland-in-gland pattern resembling a sieve. Several types of mucin-producing carcinomas are named according to the quantity of mucin and where it is stored. Cystadenocarcinomas produce massive amounts of mucin. creating a large cystic cavity in the tumor tissue. Mucinous carcinomas secrete large amounts of mucin in the granular acini of the tumor. This causes the acini to burst and the mucin to escape, giving its cut section a glassy and translucent appearance. This tubular adenocarcinoma of the colon has irregular neoplastic glands. The neoplastic cells have an increased nuclear to cytoplasmic ratio and nuclear hyperchromatism. As shown in this micrograph, signaling cell carcinomas are characterized by loss of intercellular cohesion with intracytoplasmic mucin-filled vacuoles. This produces a typical signaling cellular deformation with peripheral displacement of the nucleus. The signaling cell pattern is typical of the diffuse type of gastric adenocarcinoma, which tends to be highly infiltrative and has a poor prognosis. Solid carcinoma is used to describe the poorly differentiated adenocarcinoma with cells arranged in solid columns or masses. Based on their consistency, solid carcinomas have different subtypes. Seedless carcinoma is hard or fibrous because of their abundant stroma. Medullary carcinoma is soft and brain-like in consistency because it has little stroma. Carcinoma simplex defines the poorly differentiated adenocarcinoma with equal quantities of tumor parenchyma and stroma. Basal cell carcinoma is a low-grade malignant tumor originating from the basal epidermal cells. They occur most often on the light-exposed areas of the skin, particularly the face of the elderly, and usually present as nodular or ulcerated lesions. Clinically, basal cell carcinomas are locally invasive, but they almost never metastasize. This picture shows the characteristic microscopic appearance of basal cell carcinoma. The tumor is composed of cells with dark staining nuclei and scant, poorly defined cytoplasm. The cells at the periphery of the tumor are arranged in a palisaded pattern, while the central cells are more randomly assembled. Alright, that's all for this section. In the next section, we will continue the study of premalignant lesions and common morphology of mesenchymal neoplasms. These are the references. Thank you.